Welcome. This webinar is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar on our website at www.nhadaca.org. In terms of after completing this webinar, please upload and complete the quiz if you're interested in receiving a certificate. You can find the quiz in the file pod throughout this presentation on our website, or you can email the Training Institute at nhadaca.org. You can email, mail, or fax the completed quiz. Contact information is on the quiz itself. If you are a member of NHADACA or NADAC, the certificate for this webinar is free. If you aren't a member, the fee is $15. You will receive a certificate worth 1 CEU once you have completed and passed the quiz and paid for the webinar if applicable within 21 days. Throughout the New Hampshire Training Institute on Addictive Disorders, this 1 hour event is pre-approved by the New Hampshire Board of Licensing for Alcohol and Other Drug Use Professionals, as well as NBCC. In terms of technical support, if you have any trouble viewing the webinar, audio problems, or any technical questions, please contact us at 603-225-7060. Please email any questions regarding the material you see today to trainingsinstitute at nhadaca.org. You can upload these questions, introducing slides in the file pod to the right of your screen. Okay, the topic of this webinar is increasing hepatitis C knowledge for behavioral health providers. My name is Janet Hernandez, and you see my contact information here so that you know a little bit more about myself. I've worked in the field of prevention, intervention, treatment, and recovery supports for the last 30 plus years. And my background is in human services, public health, and counseling psychology. I live and work in Massachusetts, and the other thing I think it's important for you to understand about me is that I am a person in long-term recovery. What that means for me is that I haven't used a drug, including alcohol, for the last 31 years, going on 32. What that has enabled me to do is to be a productive member of my family, my community, and society, and to do the work that I do these days. And so I am privileged to be able to present to you about this topic, and we hope that the information is helpful. The webinar goals for today is to instruct behavioral health providers on hepatitis C and its impact on the communities that we serve. We seek to help providers to develop tools and skills to integrate hepatitis C prevention, education, and counseling, as well as linkage to care in their settings. The objectives are, hopefully we're going to be able to list at least 3 populations at risk for hepatitis C infection, explain the difference between acute and chronic hepatitis C infection, discuss at least 2 reasons why it's important to promote hepatitis C screening and testing amongst the people that we serve, list treatment factors to consider, and at least 2 new treatment options that are available for people living with hepatitis C, and provide examples of strategies to link persons with HCV care. To set the stage for the conversation, it's important for us to understand that there are approximately 5 to 7 million people in the United States living with hepatitis C. There are more people with hepatitis C in the US than people with HIV or AIDS. And so hepatitis C is the leading cause of cirrhosis of the liver, liver cancer, and liver transplantation in the US. Of all persons living with HCV, about 75% were born between 1945 and 1965. This is the baby boomer population. Persons with chronic hepatitis C infection have an estimated mortality rate 12 times higher than the general population. This should concern us all for obvious reasons. And up to 37% of infected people in the US will die from hepatitis C related complications if they go untreated. In terms of the rising rates of hepatitis C in the US, acute hepatitis C infections increased 250% from 2010 to 2014. From 2015 through 2016, the national rate of acute cases of hepatitis C increased from 0.8 to 1.0 cases per 100,000 population. And the CDC recently reported that we have a 300% increase in hepatitis C cases that are related to the opioid crisis in the US. And so these rising rates should concern us all. In terms of bridging the gap to a cure, we should know that hepatitis C can be cured in upwards of 95% of the patients that or clients that we serve. And so if we identify and screen people who are at risk for hepatitis C, then we'll be able to link them to healthcare services and hopefully cure anywhere from 95 to 99%. And this is a relatively new development in hepatitis C care. And it's very exciting news because we are talking about a cure. In terms of HIV and hepatitis A, B, and C, just want to show some stuff here by way of lifelong infection. And you see that for HIV is 100%, for hepatitis A is 0%, hepatitis B 2 to 5%, and 90% perinatal. But for HCV, it's 75 to 85%. Protective immunity from natural infection, there is none for HIV, there is for hepatitis A and hepatitis B, and there is none for hepatitis C. In terms of a vaccine, we don't have one for HIV as of yet. We do have them for hepatitis A and B, as most people know, and we don't have one for hepatitis C. The genetic material, RNA for HIV and hepatitis A, and it's DNA for hepatitis B, and then back to RNA for hepatitis C. Again, back to if these things are curable or not. For HIV, there is no cure. For hepatitis A, it's self-limited, 1 to 2% in hepatitis B, and you see the upwards of 95% for hepatitis C, and that is very promising. In terms of transmitting viral infections, you see the categories there for HIV. You also see them for hepatitis B. And then I want to draw your attention to HCV infections, or what we know as hepatitis C. It's through injection drugs, contaminated needles, syringes, cokers, and cotton, sexually. And this, the highlight here is traumatic sexual exposure. So we want to think about what traumatic sexual exposure is, and that is when there are any tears in the tissues. And so that should make us think about people who have anal sex as high risk. And then we have perinatal which is from HCV infected mother to a newborn. And these are blood-borne pathogens. And so you see here that there are many opportunities for blood-borne viruses to be transmitted during injection drug use. So it's not just the syringe, it's through the water, it's through the cooker, and it's through coming in contact with blood. All of those things are important for us to understand. In terms of what HIV looks like all over the world, it's important to understand that there's an estimated 135 million people who are infected with HCV worldwide. And the map here gives you a really good understanding of what it looks like in the Americas. Now there, we're not just talking about the United States of America, but all the way up from Canada to the tip of South America. And then you see the numbers in Europe, Africa, Eastern Mediterranean, the Western Pacific, and Southeast Asia. And so these percentages are huge, and the numbers all over the world. Important for us to understand because we might be working with populations that are coming from those parts of the world. In the US, again, the estimate is, and we know that this is a little bit different from the first slide, but the estimate is around 5 million people who are infected with HCV, and the majority of those people don't know that they're infected. That's why screening and education become really important. In terms of screening itself, we have some recommendations by the Center for Disease Control and Prevention, otherwise known as CDC. The screening for HCV infection should be done for persons at elevated risk for infection. Offering one-time screening for people who were born between 1945 and 1965 is an important thing to do. Again, the baby boomers. Some experts recommend, and I tend to agree with the experts in this area, screening everyone at least once for HIV and HCV. That way we minimize probability that we will miss people in the screening process. So the risk-based recommendations for HCV testing, and you see them here. So those people who have ever injected illegal drugs, including those injecting only once, many years ago, all people born between 1945 and 1965, all people with HIV infections, and persons or people presenting with symptoms of hepatitis C and elevated enzyme levels. Those who received blood transfusions before 1992, we have better testing after 1992, or those who received clotting factor prior to 1987. People ever on hemodialysis, folks who work in healthcare, emergency, public safety workers after they have been exposed, maybe through a needle or some other form of blood. Children older than 1 year old who have been born to a positive female, and people who have engaged in tattoo or body piercing done while incarcerated, or those who have done it with an unlicensed artist. Really important to test all of those folks. There are many factors associated with elevated risk, and these are known as the social determinants of health. You see them here. Everything from being low income, a history of homelessness, folks who have been incarcerated, history of mental health conditions or substance use disorders, communities of color who are disproportionately impacted, people who are born in an endemic region of the world. You saw those figures earlier. And then other factors include heavy alcohol use, non-injection drug use, multiple sex partners, and people with diabetes. Emerging trends for us to consider, understand, and work with. There are rising rates among young people who inject drugs. I think that 22.3% is because in the past year, 5 million young people have used pharmaceutical opioids, and this opioid overdose crisis speaks to that. And then healthcare exposure, you see there as well. And then sexual transmission of hepatitis C amongst HIV infected and HIV uninfected men who have sex with men. And so think about that, because we're talking about traumatic sexual exposure, again, where there's blood or the potential to penetrate the skin or rupture the skin. So those are emerging trends. There are some really good risk assessments that are designed to help assess people, and you see them here, and you see the link for the Center for Disease Control and Prevention. The Minnesota Department of Health has a really good risk assessment, as well as the New York State Department of Health. So we encourage you to go there and think about which ones you could use for the client population that you're working with. So we want to move on to thinking about hepatitis C infection. And so the characteristics of hepatitis C include the following. This is a virus which is rapidly replicating, and it's blood-borne pathogen that causes inflammation of the liver. Clinical presentation during the acute infection may or may not include jaundice, abdominal pain, or flu-like symptoms such as fatigue, muscle aches, and nausea. So you want to think about the client population that you're working with. And if they're talking about or complaining about these symptoms, we want to think about their possible being infected with hepatitis C. And this virus can live outside of the body for days to weeks. And so it's much longer than HIV in terms of the number of time that it lives outside of the body. And again, we don't have a vaccine as of yet, but there are wonderful scientists who are working on that aspect of it. When we look at this slide here, it depicts a healthy liver, a liver that has experienced inflammation, livers with fibrosis and cirrhosis. And so we want to think about what that looks like over time. Over the years, inflammation leads to scarring. Scarring equals fibrosis. Severe scarring, or what we call stage 4 fibrosis or cirrhosis. And cirrhosis can lead to end-stage liver disease. The compensation there, liver cancer, which is fatal without a liver transplant. And we know that there are many people who are dying because of liver cancer in the U.S. Yet we have medications that can cure people upward of 95% of the time. More about acute Hcv infection. The average time of development for Hcv antibodies when first infected is about 6 to 8 weeks, up to 6 months in some cases. And so antibodies are what our immune system produces to help fight whatever infection comes into the body. In this case, it is antibodies related to hepatitis C. This is really important for us to understand that anywhere from 15 to 25% of the people who become infected with the virus spontaneously clear it without treatment in 3 to 4 months, most times without symptoms. So there are a number of people, right? 15 to 25% who can clear the virus without any treatment. This is known as the acute phase within the first 6 months after acquiring, the infection. In terms of chronic Hcv infection, 75 to 85% develop chronic infection and may remain stable for years. That's why you've probably met people who have had the virus 20, 30, 40 years, and many people still don't have symptoms. Now, 20 to 30% develop cirrhosis and serious illness within 20 years if they go untreated, and 20 to 37% will die as a result of liver failure or liver cancer due to untreated hepatitis C disease. It's important, again, to get people to understand their status and know their status and then get into treatment. More about that later. We have a question here that, and my apologies for skipping around in slides, but we have a discussion question here that we would like for you to answer. Most people infected with HCV in the US were born between 1945 and 1965. Select A for true or B for false. We'll give you a few seconds to be able to do that. Thank you for doing that. The answer to this question is true. Remember that this is the baby boomer cohort that is at very high risk for having hepatitis C. So the answer here is true. There are non-specific symptoms of chronic hepatitis C, and we want to go through them. Again, you want to think about the client population that you're working with, what they might be experiencing, and then our role in helping them to get the care that they need. So some people might complain of chronic fatigue, others memory loss, cognitive impairment, or some type of brain fog. Not related to severity of liver disease, can be early or late. These can be severe, disabling, may be passed off as not due to hepatitis C, may not be recognized until it goes away with treatment. Now, I want to focus on may be passed off as not due to hepatitis C. Now think about the people who you're treating very, very early on for substance use disorders. And because they are new into recovery and have stopped using drugs, they might be complaining about some symptoms, and some providers might say, oh, that's related to the fact that you're no longer using drugs. Well, it can be that, but it can also be that they are experiencing symptoms of hepatitis C. So it's important to get people screened again and referred to a provider so that we don't make mistakes there. And then in terms of cirrhosis of the liver, you have compensated cirrhosis, which is asymptomatic stage, in other words, no symptoms, and then decompensated cirrhosis, where there's clinically evident symptoms and end-stage liver disease. We know that hepatitis C has been called the silent killer. Why? Because usually people go asymptomatic, in other words, no symptoms, for many, many, many years, and they go undiagnosed unless they enter into primary care for a medical issue, or they have elevated enzymes when blood work is done, or that they have end-stage liver disease has occurred and symptoms are present, or through the promotion of screening and testing based on risk behaviors and the birth cohort. So, it's been called the silent killer for a reason, and so we should make people more aware, educate folks, and test people as much as possible. In terms of moving in that direction of promoting testing of hepatitis C, this section will talk about that. So the keys to promoting HCV testing, keeping in mind that patient factors such as fear, stigma, lack of HCV information, and relatedness initiate a conversation around a patient's risk behavior for HCV and the benefits of screening. So this is really talking about how we engage people in this conversation, and that we should have in mind that there's stigma and fear attached to this, and we need to discuss the entire testing process and the possible test results. And testing can be a little bit complicated in terms of getting people to understand it. So we should include availability of provider support, tailored risk reduction counseling, and current treatment options. So we're going to review some of those and talk about what the testing process looks like, that sort of thing. Now, we know that most of the people who will join this webinar are not people who are doing testing, but we need for you to understand the testing process so that you can support people and encourage them to get tested. And while they're waiting for their test results, we can play a very positive role in supporting people and helping them understand the process a little bit better. So in terms of screening and testing for hepatitis C, it's a two-step process, and you see it here. The first thing that we do is we test for antibodies. So that's the anti-Hcv test. And so either it comes back as non-reactive, which means negative, or reactive, and that means positive. And then we have a second part that we do, which is called the Hcbrna, or better known as a viral load test. And it will either come back non-detected or detected. So it's a two-step process. And we want to take you through that process so that you better understand it, and again, so that you can better support people who are going through the testing process. So in terms of the antibody tests that I mentioned earlier, they're used to detect the presence of antibodies to hepatitis C in the system. So that's the first piece, right? Hcv screening tests designed to detect antibodies have a window period of 6 to 8 weeks. And so that means that if someone was infected today, they might not develop antibodies up until 6 to 8 weeks. So that's the window period. And it's important for us to understand that, because someone might go in to get tested and they say, well, we didn't find any antibodies. And the person then believes that they're not infected, when maybe they are infected, but their body has, as of yet, to develop the antibodies. So that's the first part of it. And the way these are done, depending on the state that people live in, we have these tools that collect saliva from the mouth. And, you know, we can get results back in about 20 minutes in terms of antibodies in the body. And then for some, it's a finger stick, and it's a small amount of blood, and this is not oral fluid. And then in many states, including the one that I live in here in Massachusetts, we don't use that form of testing. We actually draw blood because we understand that it's a more effective way of detecting if someone is positive or not. Now, a non-reactive or negative result means that Hcv antibodies were not found, and the person is probably not infected. Notice the emphasis on the word probably not infected. You're not protected from future Hcv infection, or you may still be in the window period, and that's why the probably word there, right? That the person might still be in the window period. So if it comes back non-reactive or negative for antibodies, it could mean that the person is not infected, but it might also mean that they're in the window period. So we need to provide some non-reactive counseling messages for folks, and those include the following: to stay negative, eliminate or reduce the risk by practicing. And the handout that we're referring to here talks about if you're still using drugs, don't share needles or other injection equipment or anything else that may have blood on it. Think about tattoos, piercing, and body art from a licensed artist, and explain what the consumer should expect. And so, you know, that there's universal precautions being used, that that artist has a license up on the wall, that they're actually a licensed provider, that the artist has received some type of information about hepatitis C. We need to vaccinate people against hepatitis A and B, and we need to encourage everyone to practice safer sex and get treated for any STDs or STIs that they may have, and those are sexually transmitted infection. There's an asterisk here. If a person engaged in risky behavior within the last months, they should be encouraged to get retested in 6 months. Remember that window period. And so if they've been engaged in that risky behavior, they should be encouraged to come back and get retested within 6 months, and obviously to take care of themselves. Now, if the test is reactive positive, the test result means antibodies to Hcv were found in the blood, and it also means that Hcv infection occurred and you may still be infected. Notice that it doesn't say that you still are infected, but it says may still be infected. Remember those people who spontaneously clear the virus? They will have antibodies, but if their body got rid of the infection, it doesn't mean that they're still infected. So we need further testing to determine if the person is still infected. And so we'll move on to what that further testing looks like for folks. And so before we do that, we'll talk about the reactive counseling messages that we should give to people. And that those are that the Hcbrna test measures the amount of Hcv in the blood. Now, this is not testing for antibodies. This is looking at the amount of hepatitis C in the blood. If there's no virus, the test will come back non-detected. If detected, then you are infected with hepatitis C, because this is looking for a virus in the blood. And this is a more specific test, right? Until you get the Hcbrna, assume you are infected with HCV and help protect your liver by avoiding alcohol, other drugs, and practice other risk reduction behaviors. And the person should see a doctor, learn about hepatitis C, and learn more about the treatments that are available. And hopefully the counselor facilitates access to and schedules a second test. But as behavioral health providers, we have a special role to play in that, in terms of supporting people and saying, did you get an appointment? Are you going to get a second test? When is that happening? How can we help you to remember that? Do you need any transportation to get there? All of those things that we know our people experience barriers around, and we should, as much as possible, facilitate that process for them. It's important to understand that antibody tests cannot tell the difference between someone who has chronic infection and someone who has had a past infection. It just cannot. It looks at antibody tests. Someone who has cleared the virus spontaneously, or someone who has been effectively treated. So the antibody test just looks at the presence of antibodies. We need further testing to determine other things. So in terms of diagnosing for Hcv infection, we need to do the viral load or a confirmatory testing. And so again, there's two pieces to that. One is qualitative, and that qualitative looks for the presence of the hepatitis C virus in the blood. And then the other test, which is quantitative, tests for the amount of virus in the blood. And so you might be speaking with people that say, I have 1 million copies, or they have 200,000 copies, or they have 5 million, 7 million copies. And so this test, the quantitative one, gets to that number, and the doctor will be able to work with the patient to better understand what that looks like. Now, not detected result means no current infection. So there is no virus in the blood. It means that there is no infection. Detected means that the hepatitis C virus was found, and we're confirming Hcv infection with that person. In terms of working with those results, For non-detected, there's no current infection. Some recommend another test in 3 to 6 months to be sure. Again, that window piece that we talked about earlier. And past cleared Hcv infection means you can still get infected. Now, it's important to understand that because some people think, well, if I cleared the virus in the past, or if I don't have the virus now, it means that I will never get the virus, and that is not accurate. You could have cleared the virus in the past, and you can get reinfected, and your body on the second go with it doesn't clear it. So clearing the virus one time doesn't mean that you are, or that the person is immune to this virus forever. It doesn't mean that whatsoever. So spend some time with people, making sure that they understand that. More about working with the results. Detected or viral load, there's a diagnosis of active infection. We need doctors conduct what is called a genotype testing, and there are 6 types of hepatitis C viruses in the U.S., and 75% of U.S. infections are genotype 1. I'm going to stop there to say this very quickly. Genotype 1 was very difficult to treat in the past. Now genotype 1 is the easiest genotype to treat. And so if 75% of people in the US have genotype 1 and it's the easiest one to treat, that's why you see high cure rates here in the US. So for the person to know their genotype is important when considering treatment. That is something that only a doctor can tell them after doing more testing. And then the doctor will work with them and evaluate for treatment eligibility. It can also include a team of nurses who work with people on this. And so in understanding the screening results, we'll go through it here. If we see that the antibody test is non-reactive, and we also see that the person is not infected. If we see that the antibody test is reactive and we don't have any RNA or virus in the blood, that's not detected. It means that the person was previously infected, either cleared it or was treated and is no longer infected. But if we see that there's antibodies in the blood and that there is virus in the blood, it means that the person is currently infected. Again, here for the first one, unless in window period, recently infected or immunocompromised. For number 2 is repeat the test in 6 months to be sure. And for number 3, it means that we need to actually go ahead and treat people because they are infected. Moving on to hepatitis C treatment, monitoring, evaluation, and available therapies. We'll go to that next. And so one of the things that we do is to monitor progression of hepatitis C, and the factors there that may accelerate the progression of the disease include being co-infected with HIV, persons who are older at the age of infection, males have factors that accelerate it as well, people who are insulin resistant. Here we're thinking about folks who are diabetic, and those folks who have abnormal accumulation of fat in the liver. So there we're talking about people with a diagnosis of alcoholic, or people who have diabetes and are obese, and people with genotype 3. And that's why the genotype piece that I talked about earlier is very important to understand. So all of those factors accelerate the progression. We're going to stop here and do another discussion question, And here's the question. A reactive positive test result means that the person is infected with HCV. I'm going to read that again. A reactive or positive test result means that the person is infected with HCV. A, true, B, false. And the answer there is false, because remember that that window. Also remember that a person can test positive or reactive for the antibodies and have cleared the virus, or have been cured of the virus. So the answer there is false. Thank you for participating in that. We need to also think about assessing for alcohol consumption. And we know that those of you who work in behavioral health are very familiar with screening tools and the like. So if heavy alcohol intake, we know that it accelerates the progression of liver fibrosis. We need to screen people for alcoholism. And so, think about the Cage questionnaire, which asks a series of questions. Think about SAMHSA and go to SBIRT and look at those types of questions. And some of those questions include issues like how many times in the past year have you had 4 to 5 or more drinks in a day, and 4 for women, people greater than 65, and 5 for men. So there's SBIRT. There are these tools that are available for us to assess for alcohol consumption, because we know that alcohol impacts greatly the liver, and so we need to support people in that process as well. In terms of additional aspects regarding monitoring, we need to recommend that everybody get vaccinated for hepatitis A and hepatitis B. We need to monitor patients with low or undetectable hepatitis B DNA levels. We need education on hepatitis C transmission, progressions, and we need to talk about strategies for reducing harm. So this is where all the harm reduction information that we have becomes really useful and appropriate. And there needs to be clinical evaluation for treatment eligibility. By clinical evaluation here, we mean doctors and nurses working with the patient to determine treatment eligibility. In terms of those clinical evaluations, what they look like are tests, and those tests look at liver enzyme levels, functioning of the liver, platelet counts, and screening for hepatitis B. There are tests that also assess the degree of fibrosis using non-invasive testing, and those are known to us today as FibroSure, FibroScan, and sometimes combined with Fibrometer. And so they essentially look at the liver without going in and having to do a biopsy. And we know that amongst the people, the client population that we work with, they fear liver biopsies a great deal, because that's a needle that goes directly into the liver. Can be painful, and some side effects can occur as a result of that. And so in trying to alleviate that, we should explain to people that not every person is going to get a liver biopsy. We have other scans, as the ones that I just mentioned, that look at the liver in different ways. And so in addition to that, liver cancer screening for patients with cirrhosis, and that is done every 6 months. And we look at ultrasounds and other forms of assessing people. So that took clinical evaluations. In terms of additional treatment factors to consider, we look at extent and severity of liver disease. We look at the symptoms that people may have. We also think about patient preference in terms of do they want to get treated now? Do they want to wait? It's also, their decision. We also look at drug-to-drug interactions. So if people are taking some drugs now, how well do they interact with the HCV drugs that we have available. We look at, for people who are co-infected with HIV, we look at factors such as that. And we also pay attention to adherence issues and the possibility of resistance. We want to make sure that we're treating people who are going to start a medication and follow through from beginning to end without skipping doses, that sort of thing, because that has the possibility of developing resistance. And we want to think about reinfection. There are some people who are still using substances, and so we want to take a look at that. And obviously, everyone is concerned about having the right insurance coverage to pay for their treatment. Now, in terms of providing a timeline for what treatment looks like in the US, beginning from 2016, and there were some medications developed in 2017. But you see that there are a number of medications that we have access to now. So it's not just one medication. In the past, people only heard of interferon. And right now, there are many of the people that we work with who think that that's the only thing that we have to treat people, and they have heard horror stories about interferon and its side effects. And so you see that we have 2 medications in 2015 that were developed and approved by the FDA. We have an additional 2 in 2015, 2 in 2014, and 2 more in 2013. And as we continue looking back, in 2011 there were 2. 2002 there were an additional 2. In 2001 there's an additional medication, and in 1998 you see there was 1 medication. So we have many tools in our tool belts, and that's why success rates are so high in relationship to cure rates and treating people effectively. So make sure that when you speak to your clients that you say, it's not interferon, those days are gone. We have medications, and most of those medications are in pill form, so they're oral. To learn more about treatment updates, we provided 3 sites here that you can go and look at what additional medications have been developed recently and what are the recommendations for testing and the guidance there, as well as treatment and management. And what we encourage you to do is to become familiar with these sites, have them with you on your desktop, and when you're speaking with people, you can share it with them. You can also help them navigate to those websites and answer any questions they may have. In terms of HIV and HCV co-infection, there's some things here to take into account. So if you're working with people who are co-infected, there has to be consultation and coordination between the hepatitis C provider and the HIV practitioners. There is some potential for drug-to-drug interactions, and you see the drugs that are mentioned there. The doctor, the provider, the nurses working with the person will be better equipped to determine if there will be some interactions and if there needs to be any changes in the medication. This in no way means that people with HIV cannot be treated for hepatitis C. They have been treated and been treated effectively. And the treatment recommendations should follow the recommendations for mono-infection specific to genotype. And for this cohort, but people who are co-infected, there is no 8-week treatment regimen. It'll either be 12 weeks or 24 weeks that they'll have to be on the HCV medication. But again, the emphasis here is that folks with HIV can be treated, and they can be treated effectively. Now, you might be wondering about the people who are on methadone or bup. And so there's some things here to know and to think about. Generally, people on methadone, medication-assisted treatment, or bup are safe. These medications are safe for the liver, and most people often able to complete HCV treatment. For some, however, the medications for HCV may make them feel like they're going through withdrawal, and their methadone dose needs to be adjusted so that they're comfortable. In this area here, we're talking about increasing maybe a little bit of the methadone so that they're comfortable and they don't feel like they're withdrawing. Now, for others, the HCV medications may make their body more sensitive to methadone, and they need a smaller amount of methadone. Again, the emphasis here is that the medications might need to be adjusted, and that's why coordination and communication between the medication-assisted treatment providers, methadone clinics, and others, they need to have good communication with the HCV providers. And so we can help as behavioral health people to facilitate that process by way of making sure that we connect one provider to the other and the proper releases of information are signed. HCV medications may also increase or decrease the amount of buque in the body, so a person may need to have their buque dose adjusted after starting treatment. Again, these are adjustments that are done by the doctors and the MAT providers speaking to one another, and people can be successfully treated and cured even if they're on medication-assisted treatment for substance use disorders. So moving on, in terms of treatment markers and benefits, so if they have a sustained response after 12 weeks in treatment, and they don't have any virus in their body after that, and if there's reduction in liver failure, liver cancer, or related diseases, these are all oral therapies. Some are shorter duration, 8 weeks. Some are 12 weeks and some are 24 weeks. The doctor will determine that based on genotype and other factors. And there's increased treatment tolerance because we don't have all of those side effects that interferon cause for people. And so if people are, after being treated 12 weeks, their blood is tested again and they don't have any virus in their blood after 12 weeks, it means that they're cured. Simply put, that they're cured. And we have cured hundreds of thousands of people across the US. This is really, really huge news. In terms of recommendations here for treatment, is recommended for all patients with chronic HCV infection, except those with short life expectancies, and the doctors will be able to determine what that means. In cases where there's limited treatment available, immediate treatment is assigned for the highest priority, and that means for people with advanced liver disease, either level 3 or level 4, and people who are liver transplant recipients and patients with severe hepatitis C. Transmission can be interrupted by treating those engaging in high-risk behaviors, as well as persons on medication-assisted treatment. And what we want to say here also is that there are doctors across the US that are even treating people who are still actively using drugs, including drinking alcohol. Now, some doctors will not treat that population, but some will. And where the attempt there is to create more access for people, regardless of what they're going through. Now, the highest priorities for treatment you see here, again, advanced fibrosis, level 3 or 4, organ transplant, type 2 or 3 mixed, folks with a number of symptoms, and then folks who are at elevated risk for complications. Again, that's fibrosis, but they're at level 2. Folks who are co-infected with HIV, those who are co-infected with hepatitis B, other coexistent liver disease. So think about folks who have also debilitating fatigue, type 2 diabetes, and at risk for complications. So that's all HCV infected patients. So those are some of the things that folks are taking into consideration when prioritizing who should be treated. This slide can create some anxiety for people. We recommend that you really should not be sharing this slide with patients because this can discourage them. This tells you the number of weeks, the type of medication, and how much they cost. So you see that they range anywhere from $147,000 for 12 weeks. Now, if someone needs to be on that medication for 2 weeks, you need to multiply that by 2, which becomes closer to 300,000. And the other range is 54,000 for 12 weeks. If they're on it for 8 weeks, it's much less. And the reason why we say don't share this with clients, because some of them might be using substances or have lived on the street or been in prison for a very long time, and they might throw their hands up and say, if it costs that much, no insurance is going to pay for me. Society has thrown me to the side, and that is actually not accurate. We have insurance companies that are paying for this left and right, and we have other resources to show. So we know that medications are really costly. I just talked about that. But we do have many payers, including United Healthcare, Anthem, also known as WellPoint, and 30 state medical programs who restrict who they will cover. Many say patient must have advanced level 3 or level 4 fibrosis or cirrhosis. Many say patient must be alcohol drug free, and some require urine testing. But again, it says many and not all, and that is changing. And many say physician must be a hepatitis C specialist or have hepatitis C treatment experience. Now, again, we don't want to discourage people because there are resources to be able to do this. And there are payment assistant resources that have been allocated. Now, prices are dropping, and which includes discounts, and access may improve. Insurances are paying for this across the country. And we also have patient assistant programs that have been put together by the pharmaceutical companies that produce these medications. So Gilead, they have a patient assistance program. We have a link there for you. Abivai, patient assistance program, which is another pharmaceutical that produces these medications. And then some of the specialty pharmacies can help doctors and patients with obtaining medications and co-pays. This becomes really important. I know that here in Massachusetts, Medicaid, and we are the first state in the union, our Medicaid Mass Health is paying for anyone regardless of the liver stage. And so if a person here has Mass Health, they will pay for 100% of the treatment regardless of liver stage, that sort of thing. And as Massachusetts goes, other states in the union pay attention to what we do here, and they follow suit. So we're paying attention to that because that will create greater access for people down the line. We want to give you additional payment assistance programs here, and you see them there with 8 toll-free numbers, and these are foundations that help people pay for their medications, that sort of thing. And so if we must lead with something with patients is, there's numerous ways of getting you the medications that you need, including a resource for people who are co-infected with HIV and hepatitis C. And so you see the links there. Please check those out. The next few slides are really about linking people infected with hepatitis C to healthcare services. And so, the way that people can get connected to those services is when they come in contact with primary care, emergency room, HIV testing sites, syringe exchange programs all over the country, substance use disorder treatment programs, such as the ones that are represented in the audience of this webinar, mental health treatment programs, methadone maintenance clinics or other medication-assisted treatment facilities, sexually transmitted infection clinics, community-based outreach to actively injection drug users, homeless shelters, and there are a number of others. So, linking people to care begins at all those levels. Now, most of the people on this webinar are substance use disorder providers. So think of yourself as a point of contact for people to get the care that they need. And we should think of ourselves as people responsible for creating awareness and providing supports to people. In terms of linkage to hepatitis C care, again, through the promotion of Hcv screening and testing, so one-time testing of people in the birth cohort, as we talked about earlier, that's the baby boomer cohort, or the folks with an identified risk factor. So we talked about people who are actively using, people who use alcohol, people who are diabetics, people with Hcv infection. Those are folks at high risk. And we should be thinking about referral to a healthcare facility for the testing that is needed and evaluation of the treatment. We should think about entry into primary care for non-HCV medical issue and already within the continuum of HCV care. And so, again, the emphasis here is how do we think about ourselves as people who work in behavioral health, as people who can be linking people to care, linking people to testing, linking people to follow-up, and then supporting those people when they come back to our treatment facilities and helping them understand what they're going through and how this treatment can support their long-term recovery, right? Because we know that, once people get into recovery, they start feeling good about themselves. Many, if not all, they start worrying about health conditions, including HIV, hepatitis C, sexually transmitted infections, and that sort of thing. And if they're not thinking about hepatitis C because of the